Welcome everyone to week 5 of Joint School Live. Time really does fly fast, even in these strange times. And I am absolutely honoured and delighted today to be joined by Mr. Jeremy Latham, who will be joining us for a live question and answer session on everything to do with hip replacement surgery. Now, it's a real pleasure to introduce Mr. Jeremy Latham, who has been a hip specialist since the other side of the millennium, so he really has a wealth of experience to dip into and share with us. He works out of the Nuffield in Wessex in the southeast of England, and outside of a hip replacement, well, his day job as a hip surgeon, he describes himself as an enthusiastic but frustrated piano player, an occasional skier, a sailor, and interestingly, he's also pretty adept at making his own videos. And so I would really recommend to anyone who has an interest or is curious about hip surgery and hip replacement surgery and revisions and all the kinds of things we'll be touching on today, to check out the Latham Hip Surgery YouTube channel as well. And so I'll be bringing in Mr. Latham here now, so he can join us on the channel here. And there we go. Hello, Mr. Latham. Fantastic. Now let's see.
There. Hello, Axel. Thank you for inviting me.
Hello. Thank you so much for joining us for this project. It's this is, as you well know, it's something rather new that we're doing in response to the strange circumstances that we're in. But in many ways, YouTube is nothing too novel for you. I think you've been building your channel for quite some time now.
Yes, I really enjoy all this techie stuff. I've got a little home studio, Axel, which I've got a video switch and all this sort of stuff. I've been accumulating bits and pieces over the years because I think video is a really good way of getting knowledge across to people in a very personal way. I think if you look at people's websites, the text can be very sort of hard to get through and it's not particularly helpful, whereas connecting a face with the message that one's trying to get across, I think is an excellent way of imparting knowledge and getting trust as well. That's particularly important these days because people are going to be very worried about going back into hospital to have treatment. Yeah, absolutely, absolutely. And I think by and large, there'll be across the board a move to more remote care and virtual follow-ups. And so in some ways, this is sort of becoming a new kind of normal. It will be, yes. And we've all got to adapt to that and gain the skills because it's quite challenging sitting in front of a camera and putting yourself out there. It's not that straightforward and makes one feel very uncomfortable at first. But the more you do it, the better it gets, really. And I really enjoy it. Yeah, indeed. And of course, a video can replace everything. It certainly can replace a proper examination. And no, exactly. But generally, what we're finding with both the Joint School app and the videos here on our channel is that we've been getting some really lovely messages from people finding them supportive and helpful. Yeah. And we've had a real big bunch of questions for us to tackle here today. And of course, if anyone is watching this just now who feels that actually that bit I'd like to know a bit more about, or wait a minute, are they moving ahead without touching on this topic, then please do let us know in the comments here, either on Facebook or on YouTube, and we will see if we can slot them into this session as well. Fantastic. And by and large, what I've done with the questions that we've received so far is kind of organizing them. So we're beginning a bit more about your experience and kind of hip replacement surgery from the point of view of the surgeon, as it were, from your point of view. And then very simply doing a sort of pre-operative section and a post-operative section. So kind of, roughly speaking, questions grouped around the sort of things that people will or have been asking us about, about the process of getting ready for surgery or thoughts about having the surgery and so on. And then similarly after surgery. A bit of a caveat and a flag, as ever, I've got the sort of the safety hat on and that kind of thing. Of course, nothing we discuss here is personal medical advice. And the intention is really that we're hoping to and helping to cast light on some of these issues and hoping to alleviate some of the questions and perhaps anxieties that very understandably can arise when one has been booked in for a hip replacement, or perhaps had it postponed because of what's happening,
or
Yeah.
maybe even just has a sort of, maybe even, I know from a few people who've sent in questions that they've not necessarily been given the full diagnosis or been booked in for surgery, but
Yeah.
they have a hunch that this is something that might be coming their way, so to speak. And so,
Yeah.
um,
Well, just I thought by way of a sort of introduction, Axel, I thought it'd be quite good to just show people what you can see on a, when you come for and have a clinical assessment. So here's a graphic of an arthritic hip. Here you can see the hip joint is very diseased compared with the other side. It's just a graphic rather than the actual thing. But you can see the hip joint is a ball and socket joint. It is covered in cartilage, which is a smooth water protein layer, which allows the joint to move and shock absorb. When you get arthritis, it becomes very gnarly, very rough, and of course, very painful. And this is what it looks like on an X-ray. There's a normal hip, and here's the abnormal hip. This is a case of a patient who's got what's called dysplasia of the hip joint. So the hip joint hasn't really formed properly, and it becomes, the joint is rather shallow and therefore subject to excessive loading, and that causes a lot of pain. So that's what we see when we have hip surgery, or that's what you have if you're going to have hip surgery, is painful arthritis of the hip joint, which is very limiting. It causes stiffness, disability, inability to sleep very well, and of course all the symptoms that patients present with, gradually deteriorating mobility, and particularly if you're elderly as well, of course, the risk of falling and developing muscle and bone loss, which of course increases one's disability.
Thank you, Mr. Latham. I think that's a good starting point indeed, and I think you know, from what we've heard, there are certainly people out there who've been in the situation of seeing that X-ray and feeling a bit frightened, really, of what.
Yeah, I mean, it is scary. You're subjecting yourself to surgery, which is to improve your quality of life. It's not life-saving surgery. And so the mindset that people have is very different from, say, having surgery to remove a cancer or to have cardiac surgery. These are very different approaches to how we as humans evaluate risk and benefit.
Yeah.
And of course, with the COVID problem, there is that increased risk that if you were to develop the illness whilst you're recovering from surgery, of course, that does increase the risk of complications. And that's something we haven't really seen that much just yet, because we haven't started doing elective surgeries. That's going to be a bit of an unknown. I think it's really helpful to get the message out here now that the hospitals are all gearing themselves up to start elective surgery again, which is vital. We have to start doing elective orthopaedics, diagnostic work for cancers, heart investigations, the whole thing. And we don't really know how that's going to play out. So the Department of Health is really playing a very cautious game at the moment, which one can understand.
Yeah, absolutely. And I guess perhaps more than ever, you know, something that I've certainly learned over the past few years of working on these digital tools to help people who are getting ready for surgery and recovering is that, you know, any clinical team, any care team, any intervention, you know, as a patient, you're part of that team, and you're perhaps, or you're certainly the most important member of that team. And I think now, in the situation we are in, and with so much uncertainty, perhaps more than ever, there's perhaps an added need for patients to be informed, know about the possible risks, know what to look out for, and know a little bit about the steps that you can take at home, both before and after surgery.
Well, this whole process of shared decision making is so important and involves a huge amount of education before surgery. The reality is, looking at the Department of Health information about elective surgery, is that patients are going to have to self-isolate for 2 weeks before they come into hospital. And so their immediate family who live with them, say, so they must self-isolate, which is quite an aggressive move. There will also be testing done when they at that 2 week period, and again before they come in. So a very, very careful pathway here to try and minimize the risk of developing the illness whilst you're recovering from surgery. And also, you know, if you were to develop symptoms, of course, your operation is then postponed.
And of course, these things are done to try to reduce the potential risks, but they are indeed likely to add further challenges to what might, you know, or what can be a quite daunting experience at the best of times without these
added And I think where the private hospitals and standalone orthopaedic units, I mean, I trained in various orthopaedic units around the world, and particularly in Oxford at the Nuffield Orthopaedic Centre, which is a standalone orthopaedic centre, and in Birmingham, the Royal Orthopaedic Hospital. These were built from old TV sanatoria from years and years ago, and they became orthopedic hospitals. And I think we're going to see a lot more of the development of standalone units in this post-COVID era to try and reduce the risk of infection.
Yeah.
And the private hospitals, of course, are geared up for that because they have not been treating COVID positive patients generally.
Yeah, I mean, there's quite a lot to dig into and explore on the topic of the
Huge
impact
amount.
of COVID-19 on orthopedic surgery, on hip replacement surgery in particular. And I think we could very easily do a full session on that alone.
Exactly. Days over it, Axel.
Yeah, indeed. So I think to ensure that we cover the questions that people have so kindly sent in to us, perhaps we sort of close off the COVID-19 section, so to speak. But by picking up one of these questions that was sent in, which is, what would be your advice to people who are out there, who are watching this now, who have been informed that their hip replacement operation is postponed because of the crisis?
Well, there's a couple of issues I'd really sort of focus on if I were a patient. I mean, obviously, it's that fear of the unknown. When am I going to get called in? How do I plan my life for the next 3 to 6 months? Hospitals are, I understand, the NHS hospitals are in close contact with their patients. They're going through waiting lists, trying to prioritize patients who are wanting to have their surgery fairly urgently. There are a variety of different conditions in hip surgery, some ranging from where the bones can collapse due to failure of the blood supply to a more indolent pattern of arthritis. And it's trying to identify those more urgent patients to bring them forward as much as one can in order to do expedient surgery on them. But I think that if I was a patient, I'd want to know, where am I on the waiting list? When might I expect to come in? And what steps are you taking as a unit to where I'm going to try and reduce the risk to me of developing the infection? What can I expect to do in the next few months? The other thing that one can do is try and stay as fit and active as possible, doing some limited exercises within the limits of pain, trying to keep your balance and your coordination as best as you can, doing some light weight lifting, perhaps even just some lifting a bag of shopping just to keep your upper body strength going, and also to maintain cardiovascular fitness as best as possible. But of course, if you've got a painful hip, everything you do it causes intrusive symptoms, and it's very off-putting trying to do even the simplest thing like washing and dressing yourself. But trying to maintain a level of activity which doesn't cause intrusive symptoms, I think, is crucial. And trying to stay positive, which is very difficult, of course.
Yeah, no, absolutely. And I think that's an excellent summary. And it's really those little things, small positive changes to the day-to-day, little routines, and finding ways that can together help to make a bit of a difference, and hopefully help to inform someone. Knowledge is medicine in itself, as some people would say, right? And
absolutely, we are complex beasts. We're a mix of psychological and physical factors, each of which interplays with the other. Yeah. And it's important to, when you try to, as a surgeon, you try to help your patients manage both aspects of their illness, which is, of course, the art of medicine, which no amount of telemedicine and artificial intelligence, I think, will ever replace that relationship between two human beings discussing the treatment that another person's going to have.
Yeah.
And that's why it's so important to keep these lines of communication open. I think that's the key, really, to getting through this next phase, is having clear lines of communication with the unit that's going to do your operation. Mm-hmm. In the private sector, it's much more personal because you've got a relationship with your surgeon. And I'm having regular telephone and email consultations with my patients, keeping them updated, letting them know when we can start seeing people face to face again and start doing some surgery.
Yeah. And these the things, these are exactly the things that we're hoping to help to enable and encourage with the Joint School, and indeed with these sessions too.
Yeah, I think the Joint School app's a really good innovation, Axel. It sort of builds on what you've got already with the myrecovery app, taking patients through this phased recovery from their surgery. But I think it's equally important to look at this pre-operative journey, even if there weren't COVID, optimizing people's condition, both physically and mentally before surgery. There's huge evidence out there that if you optimize people before they have surgery, they get a far better outcome. They've had their expectations discussed and dealt with and managed. And the more you know before you come in for your operation, the more confident you'll be emerging from that episode of care.
Yeah, certainly, absolutely.
Yeah.
Well, so then to then move on to those who sent in questions that are sort of a little bit more specifically directed to you, or sort of surgery from the point of view of the surgeon, so to speak. So the first one of these questions that was sent in, so it's quite a fun question. I think maybe from someone who quite likes to doing, using their hands for practical work and things like that. And their question was, when doing a hip replacement operation, what is your favorite part of the procedure?
Wow, that's a good question. It's a bit like flying a plane, I think. It's that the frisson, that excitement of the first moment you put the blade, the scalpel to the skin. When you are committed, there's no going back then. And to me, the whole build-up for the surgery is that moment, knife to skin. That's what we call it in theatre. And that's at a documented time. So the whole process of the diagnosis, communicating with the patient, planning the surgery, bringing the patient into hospital, that one moment is the culmination of that whole process. And what happens next, of course, as again, the aviation analogy, to land a plane perfectly, you have to make a perfect approach. And therefore, it's all about how you get to that point. If you get to that point in a coherent, logical way, the rest of it then flows. So it is that's the crux of it to me. And then I never rest easy until I've seen the post-operative x-rays. So the next day, I have a bit of that day I have a bit of a restless day, thinking, is it where it should be? Is it where I believed it should be? And of course, 99.9% of the time it is. But most surgeons have a slight obsessive compulsive trait in them. And I never rest easy until I've seen the x-rays the next day.
Yeah, no. I think that's a really interesting answer, and it touches on the idea, of course, that the operation itself is just one step in a large process, but that knife to skin moment is sort of the taking of that step, the sort of the
absolutely. There's no going back after that. You are committed. Then that's it.
Yeah. And of course, just a quick note about the positioning. That's something that you and other surgeons, but you've been quite at the forefront of using digital tools intraoperatively to help with positioning.
Yeah, we do a variety of things, Axel, and I got very interested in, and there's a huge growing body of evidence now for looking at not just the hip in isolation, because it's very easy to think of the hip as just one joint in the body, but actually it's like the old song, the hip bone's connected to the thigh bone's connected to the knee bone, all those things. And if you don't take into account how the other joints of the body move, how that patient's other locomotor problems might affect the hip, then you're not taking into account significant biomechanical aspects which could affect the performance of the hip joint, both in the short term, the risk of dislocation, getting the leg length wrong, but in longer term, particularly in younger patients, that hip failing years before it should do. So there are some emerging technologies now looking at the way the spine and the pelvis move together, doing preoperative CT scans to plan that operation very accurately, and using 3D printed custom-made jigs to reenact that preoperative plan. And that eliminates a lot of error that does creep in through any complex psychomotor procedure. The other thing we're looking at, of course, is the use of the robot, the surgical robot, the Mako robot, which again uses CT-based planning to give a very accurate preoperative plan. Before the surgery starts, you plan exactly where you're going to put the components of the hip replacement, feed those coordinates into that personalized plan, and then the robot is brought in at critical stages of the procedure. And it actually stops you from putting the components outside of that window of the perfect position for that patient's pelvis.
Yeah. And I think it's worth saying, because I know we do get a fair amount of questions around the use of robots in surgery, that we're quite far from from robots actually doing the surgery as such. Here it's about assisting the skill and the expertise of the human surgeon. That's very much what's happening.
I think definitely not in my lifetime, Axel, and almost certainly not in your lifetime either. But I think what we will see is increasing use of augmented reality, virtual reality, holographic representations, which will be there. I can imagine this is very sort of sci-fi stuff, but there is technology out there which can do this in a very raw way, but actually calling up a hologram next to the patient on the operating table with that patient's imaging and instructing the software, the hardware, to spin stuff around so you can look at the three-dimensional aspects of that patient's preoperative anatomy.
Yeah.
And then, you can imagine a bit like, again, going back to the aviation analogy, flying a plane on approach with on instruments and telling you exactly where you are. And when the circles coincide, you've got your preoperative plan achieved. So I think there's going to be increasing use of that incrementally. Yeah. I mean, it's hard to see where the revolution's going to be, but revolutions come out of incremental gains in a variety of different technological spheres. You look at the history of hip replacements. So John Charnley in the late 50s, who was an engineer by training, he saw the technological improvements that happened and the revolutions that happened after the war, particularly in polymer science, the advent, of course, of antibiotics and safe and predictable anesthesia. Yeah. And his genius was looking at all these different silos of technology and having the vision to bring them into the world of hip replacement surgery. Yeah. So that's how things happen. That's how these clever entrepreneurial brains suddenly make a leap. They've got all the technology and all the map below them, but they see the shape in it.
Yeah. No, indeed. And we will have one of the surgeons who's currently at Wrightington, where Sir Charles practice, will be joining us here on Joint School to give exactly that, an overview of the history of the hip replacement.
Yeah.
Very proud British history of innovation and success, really.
Well, I still have his behind me here on the bookshelf over there. I've got his Sir John's book.
Oh, right. I see you've also got a human skull there.
Oh, yes. I've had a skeleton since my sort of early junior surgeon days. I mean, it's much the same now, I'm sure, for surgical training. Back in the old days, we had to do what was called the primary FRCS, which had something like a 10% pass rate, and you had to know everything about everything related to anatomy, physiology, pathology. So most surgeons had a half skeleton handed down through the generations.
No,
it's probably not allowed anymore because of the Human Tissue Act, but I've kept very great care of this skeleton for over 30 years. Huh. And it's lovely to have it because it's good to feel when you're looking at odd anatomy, say in a patient who's got an unusual problem, to go back to the normal anatomy and actually feel the bone, to look at the bone and relate that physical, tangible thing in your hand to the three-dimensional map and plan you have in your head. Yeah. And that's a very important part of, I suppose, the surgical mindset. Relating normal to pathology and how those things interact with one another.
Yeah. So from human bones to robots, I think that brings us quite nicely to the next question, which would be sort of the final one in the kind of the surgeon's point of view section. So
sure.
And that it was very closely related. But the question is, and it was sent in by someone on Facebook just this morning. And they're wondering, since you started surgery in hip surgery in particular in the 1990s, what is the one single biggest change?
I think the biggest change professionally has been the introduction of the National Joint Registry.
Okay.
This is an organization which started gathering a head of steam really in the late 1990s based on the Swedish National Joint Registry. A registry is just a deposit of information. So Sweden and Norway developed a joint registry many years ago. So every device that was put into a patient was recorded. Mm. So the patient's diagnosis, age, demographics, what implants they had, and how that patient did in time. So they recorded from the time the implant went in to if and when it failed and had revision surgery. And so that became really an internationally recognized source of extremely good data in terms of the longevity of hip replacement, which ones did well, which ones didn't do so well. Did men do better than women or vice versa? Which diagnoses were the most favorable in terms of outcome? And so the British Orthopaedic establishment set up the National Joint Registry of England and Wales, and it became active in 2003. So since I've been a consultant, the NJR has gone from being just a very slow starter in terms of gathering data. People weren't particularly compliant about uploading it. So now I think nearly 2 million joints on the registry. So a huge and powerful set of information and data, which can inform surgeons very early on if the implants they're using are not doing particularly well. Is there an earlier than expected revision rate? And of course, the NJR and surgeons as well in this whole sort of pool of knowledge were vital in finding out and detecting that metal on metal hip implants, some types, did not do very well at all. So it was set up as an early warning system, really, and it's been particularly effective at that.
Yeah, interesting. Yeah, and as a Swede, I'm always very happy to hear that. Yeah.
Well, exactly. You Swedes are out there, aren't you, with your non-social distance, or we had social distance,
we're
but non-lockdown. Let's not go there.
Yeah, no, we're moving on from COVID-19. So, moving into the next section, the getting ready for surgery section. So here, I mean, again, there's many things to touch on, but I've sort of ordered the questions sort of in frequency and kind of similar kind of topics. And one of the first questions that we tend to get in, and that we did get in this case, is how long does the operation typically take?
The actual time from knife to skin till the last clip is in the skin, it's about an hour for most people. Of course, that depends on the complexity of the surgery, how big the patient is. Obviously, if they've got quite a lot of padding, it can take a bit longer. But the whole episode, from the time the patient walks down to the operating theatre, into the anaesthetic room, and then out into recovery, you're looking at about 2 hours altogether.
Okay.
That's going to increase, though, because I think it's a good point, because as a result of COVID and infection control procedures, we're going to be very different in the pace of work we do from now on. On a good day, we could do 5 joints in a day, starting at 8:30, finish at 5:30, 5 hips, very doable. I think what's going to happen now is patients will be coming into hospital. They'll take a lot longer time to be ready, to be prepared to come to theatre. And of course, the turnaround time in theatre is going to be massively increased as well, because there'll have to be a sort of in-depth cleaning process of every bit of that journey from patient's bedroom to theatre. Yeah. So we're probably going to be down about 40% in terms of activity. And I think that's going to be indefinite now.
Wow. So we're talking about a real significant change, and
definitely,
change in the practice of surgery in general, and
exactly. And that's purely for the safety of patients. We can't go back to those old ways, which were very effective, very efficient. I mean, in terms of time management, it was brilliant. In the US and a lot of European countries, some people in the UK as well, run 2 operating theatres. So they'll have a patient in each room, and the surgeon, the consultant, will go from one theatre to the next. That's gone. That sort of double room operating, 8 to 10 joints a day, and under one surgeon's name, it's finished. You can't do that. You cannot go from one room to another without, of course, disrobing, getting your PPE on, all that sort of stuff. So there's going to be some profound and significant changes in workflow and work patterns, I think.
And a related question, which will surely also be impacted by the new situations we're in, is how long one might expect to be in the surgical unit or the hospital after a hip replacement.
Well, that's a good point. Going back to what you asked me before, what's changed in the 20 odd years I've been a consultant. When I first started doing joints, people have been in hospital 10 to 14 days. There's a fantastic video or movie, a 16mm movie of a surgeon called Peter Ring, who worked at Red Hill Hospital back in the 60s, him doing a hip replacement. And an enormous incision he did, or the whole length of the thigh almost. And this was I think it was at Red Hill Hospital. And the patients filmed afterwards. And he said, after about 3 or 4 weeks, the patient's ready to go home. So back in the 60s, patients were in hospital till they were fully recovered. Now patients are in 3 or 4 nights maximum, and it's definitely going to be the case that patients will be sent, will be ready for home in a day or two. There will be increasing use of ambulatory surgery centres, I'm sure, in this country. They're very big in the US. There's a company over here which is trying to set them up. They have one in London. I think that's going to take a bit longer to roll out because they rely hugely on high efficiency. And of course, no one knows how this COVID problem is going to affect that.
Yeah. So there's a lot of unknowns out there, but certainly there is a lot that we do know, and that a lot that can be said to hopefully help to reassure people in this.
Absolutely, yeah. There's lots of positives here, Axel. It's an opportunity to reset how we work and to stand back and think, what's happened here? What do we learn from this in order to improve patient safety? Because that's always got to be our focus. Yeah. What do we do? How do we construct safe pathways of care to allow patients to recover safely from surgery before they even get to hospital? How do we make sure, as best we can, accepting it's a human system with dealing with random biological events? How do we limit the risk to people as best we can? And I see this as a huge opportunity to reboot what we've done to date.
Yeah, and I think you're right. And generally, there's been this move sort of over the past few years. Perhaps it's been picking up speed of moving from sort of reactive to proactive healthcare, and people undergoing different types of treatments becoming more partners in their own care. And I think indeed this is something that will accelerate those positive developments.
I'm certain it will. Yeah.
So we've had some great questions coming in through Facebook, which I think we'll get to via this next one, which is one that's also popped up quite a few times, and it's to do with the dreaded nil by mouth, the fasting. Instructions. And so there's a few questions around this, which I'm sure you've heard many times, but generally it would be sort of why is it important? Can I brush my teeth on the evening before surgery and on the morning? I take regular medications. Now, of course, there will be some variations on that, but I'll leave it to you on this one to expand on.
Well, it's a very good point. We become much more sort of nuanced about this, I think, in the last few years, understanding that you can't expect people not to have taken anything, particularly fluids, for 12 to 18 hours before surgery. It's physiologically wrong. So there's been a lot of work done on improving perioperative care, particularly preoperative care. Patients now at preoperative assessment are advised very explicitly about when to take their medication. They're given electrolyte drinks often to take before they come into hospital to improve their fluid balance. And we're much more liberal now. The anaesthetist is much more liberal about allowing patients to drink. So we know if the first patients of the day, we have a list of who's going to get done first. Often we do the more complicated cases first, people who've got significant medical problems like diabetes and things like that. So anybody else who's later in the day, we allow them to drink water ad lib until probably 2 or 3 hours before surgery. So they're staying hydrated. In terms of medication, obviously some medications are critical, others less so. Things like, of course, diabetes control is essential. You don't want your blood sugars to go wayward in that time between coming into hospital and having your surgery. That's the last thing you want. So we're much more personalized. One doesn't have a blanket approach to these things. One looks at the individual and advises accordingly. But generally, it's far less rigorous than it was. Obviously, you don't want to have a huge supper the night before or a bacon sandwich before you come into hospital. It's being sensible about it, understanding that you want to have a relatively empty stomach, particularly of food, for several hours, 6 to 8 hours before surgery. But water gets absorbed very quickly from the stomach. And so the risk of regurgitation of that water, which is the life-threatening problem of having a full stomach, when you go under with an anaesthetic, all the muscles which control the contents of our abdomen relax to a certain extent, and that can cause reflux. So food coming up the esophagus and then getting into the lungs, that's the thing to avoid at all costs. But in hip surgery, we're doing most of the time that people are having regional anaesthetics, so a spinal epidural type anaesthetic. They're awake more or less during the operation. They're fully as best they can be in physiological control of their bodies. So it's not like the old days where you were given an enormous general anesthetic, put on a ventilator with all of the complications that can arise as a result of that. Anesthesia these days is much lighter, much more in tune with the patient's physiology.
Yeah, yeah. No, I think there's some good points there about how things are changing. Although wearing my safety hat, I just have to flag for everyone out there that, you know, follow the pre-op plan and
Absolutely.
instructions from your team, and there may well be variations, and there may be very good reasons that you're given the plan. So that should be the default, of course.
Yeah, and most units that do high volume hip surgery or hip and knee surgery, whatever they're doing, will have very clear and explicit guidelines which will guide you through. There'll be a hotline if you're concerned, if you want advice, you know, the day before, whatever, the morning of. So there's always somebody there and to help you if you've got an urgent question.
Yeah, indeed. And in your answer just there, you touched on the anesthesia and how that's changed and it's becoming lighter. And I've found over the past few years that many people are actually more anxious about going under and the anesthetic than the actual than the procedure itself. But bearing in mind that you're not an anaesthetist, could you expand on a few points around anesthesia and the most common options?
Okay, well, I've worked the same anaesthetist for over 20 years. Mark Platt was allocated to me when I first started in Southampton at the General, and we worked together and became very good friends over that time. So he's done all of my lists over the years. We have a very good working relationship. He's a brilliant anaesthetist, great clinician, and we understand each other and how we work extremely well. So we have a great team. So in terms of anesthesia, what his preferred anesthetic is, patient comes to the operating theatre walking, if they can. They're not given a pre-med. He then will put what's called a spinal anesthetic into the patient. So a very fine needle is inserted into the back. The patient sits on the side of the trolley, leaning forward. He puts some local anesthetic in the skin, passes a very fine needle into the spinal canal, and then puts some local anesthetic in there. That then makes the patient numb from the waist downwards, so you can't feel anything, not aware of anything. And then he will provide the patient with a sedative, so an intravenous sedative, which is continuously pumped into the body. He's able to titrate that according to how conscious or unconscious the patient wants to be. We have a lot of patients who want to chat during the operation. You know, quite often hear, "What's he doing now? What's that hammering?" And Mark will tell them what's going on. Conversely, a lot of patients just don't want to know anything about it, and he will keep them relatively flat, unconscious, but breathing. They're breathing on their own. That's the crucial thing here, which means that blood pressure, respiration, all of those reflexes that keep us alive and healthy are maintained without significant sort of interruption and messing around, really. So it's a fine balance between the patient's own physiology and what's being done to them. And, you know, people like Mark Platt are just geniuses at doing it, really.
Yeah, well, indeed, and that with a slight danger of asking another question that perhaps would be more appropriate for Mark Platt. There's a related one that of course is a big concern for many, which is around pain and discomfort after surgery.
Yeah.
And some of the questions that we received about there is sort of, how painful is it afterwards? What are the options for controlling pain? What if pain isn't controlled? And how long until the pain starts improving after surgery when you've had a hip replacement?
Okay, well, the great thing about the spinal anesthesia is the effect of it lasts for several hours post-operatively. So the patient is blissfully unaware of any significant pain, probably for 6 to 8 hours after the procedure. And the nurses are very good at timing when to give the patient pain relief. So we have a range of things available to us. And Mark will write up a cocktail of drugs to be given at various times, anticipating when the patient starts to become more aware of the lower part of their body and trying to manage that slowly increasing level of pain that's coming from the traumatized hip as a result of the surgery. So a range of drugs are used, from opiates like morphine powerful synthetic opiates, codeine, things like that, anti-inflammatory drugs, and just plain old paracetamol. We can give paracetamol intravenously, very effective pain relieving medication. But the main thing about, I think, with back pain is it's again a complex psychological and physiological thing, and people perceive pain in different ways. Some people are very, very pain sensitive. Others have a very high pain threshold, and understanding that patient's particular needs is part of this whole process. And everyone's very much involved in making sure that patients don't have severe pain, because what we want is patients to be moving very quickly to restore their reflexes, get their heart and lungs and everything moving. What we don't want is them being inhibited by pain, which slows down their rehabilitation and increases the risk of complications like deep vein thrombosis and infection. We want people up and about, and often we get people up on the same day.
And indeed,
so the level of pain control that we offer it's really very focused, and it's aimed at really getting that patient going quickly.
Yeah, absolutely. And indeed, getting up and about and getting active again, gently but regularly, is an important part of the pain management process as well, isn't it?
Absolutely, yes. And again, that comes back to that this interaction between psychological and physical factors. If you're aware that your body's working again, and you want to get up, the brain's very good at inhibiting pain and how we perceive pain. So it's this interaction between psychological and physical factors is the crux of all this, I think.
Yeah, absolutely. And something that I've certainly heard from many people, both after knee replacements and hip replacements, is that while there is discomfort after surgery, it's a very different pain from the pain that the arthritic pain many people have been suffering with to quite a significant extent before surgery, and that pain has kind of gone. Many cases.
That's a real phenomenon. Yes, people wake up from the operation and say, "God, my hip can move again. It hasn't moved like this for years. I don't have that terrible grinding arthritic pain anymore." It's transformational, really. Surgical pain gets better very quickly. Everyone's bruised themselves or had a cut. It's sore for a few days, but gradually it just sort of all calms down. Within a couple of weeks, most people have a little bit of discomfort. The muscles are aching a little bit, particularly after exercise. But by 6 weeks, most people don't need any painkillers. And by 3 months, they've mostly forgotten about their hip. So that's the sort of time scale we're looking at.
That's indeed the goal, isn't it? The
absolutely, rapid recovery.
Well, which is leading us very nicely into the post-operative segment of this session. Before we move on, though, we've had a very good question sent in to us just now in a comment via Facebook, and it is from someone who has mild osteoarthritis on both hips, and they had an X-ray about 6 months ago showing that it was mild. They mentioned grade 2, and they're wondering how long should they expect it to take before it's bone on bone, which is something that they've come across as a term, and I'm sure many people watch this as well.
Well, to be honest, Axel, the X-ray is just part of the whole diagnostic process. The X-ray doesn't tell you how severe someone's symptoms are, and it really doesn't help in the timing of surgery. It's just a snapshot, and people can perceive arthritic symptoms, very intrusive symptoms, from a relatively normal-looking joint. Arthritis isn't just the joint surface; it's also the soft tissues around there, and the bone as well, and the blood supply. So you can have a relatively normal-looking X-ray, but quite severe arthritic symptoms. Conversely, you could have bone on bone in a hip joint, and because it doesn't move very much, it's not particularly painful. So I think the statistic to bear in mind is that 70% of patients who have osteoarthritis of the hip will end up having a hip replacement within 10 years of the diagnosis.
Right, okay.
So by the time you've got symptoms, the clock is running, and within 10 years, you'll have had a hip replacement. So it doesn't matter if it's bone on bone or not. We'd never make a decision to operate based solely on the X-ray. The X-ray is useful in terms of confirming the diagnosis and also planning treatment, but it's no more or less than that.
Okay, I think that's a really helpful ballpark to have something to sort of wrap one's head around. But
But numbers are good. We like numbers, don't we?
We like numbers, and whether or not they are absolutely accurate for an individual, but at least they can help to sort of set goalposts and some ideas of what to expect, and that's generally really what we're what we're aiming to achieve with this call.
Exactly.
And I think there's been, the past few years, there's been quite a few interesting studies on people who don't have any pain or other symptoms, and all sorts of abnormalities are found. And so there's this slightly counterintuitive, and I think in some ways disappointing realization that the X-ray imaging, MRI scans, it isn't necessarily the one on and be all.
Exactly. It's part of a process. I mean, it's back to old traditional clinical skills. 80% of the decision to treat somebody is in the history.
Yeah.
How has this happened in the context of that patient's life? How old they are, what their working history is, what other illnesses they have. How does that, where is the pain? How is it triggered? What's relieving it? What activities are you not able to do? Then that's the clinical diagnosis is help with the examination. Is the hip painful to move or not? And then we start going down this diagnostic pathway of investigations. And at the end of that, we have a diagnosis, we have a prognosis, and we have a treatment plan.
Mm-hmm.
So that traditional method of diagnosis and treatment is very, very effective and has stood the test of time over hundreds of years, really.
Yeah, well, fantastic. I think I think we've covered some really, really good points there in sort of getting ready for surgery, and indeed we're sort of bleeding into the post-operative phase. If you pardon the
yeah.
But so if we move into now the section on after surgery, post-operative things.
Yeah.
And so we've had some very good questions there. You touched on a few that sort of general milestones after surgery, and I think that's something that many people have asked. How long until I'm back to normal, or how long until I can do the activities I want to be doing? How long until I can return to various activities? What kind of expectations can people have there after a hip replacement?
Well, orthopedic surgeons work in units of 6 weeks generally, and that's just a sort of reflection of the normal time it takes from let's say an injury response to maximum repair response to resolution. So it's a sort of curve like this. For most people having hip replacement surgery, the first 6 weeks is the hard bit. That's the time when you're not sleeping that well, feeling a bit sorry for yourself. You're wondering why you ever had it done in the first place, but you understand that the pain's better than it was, and you can start to see what the point of it all was. Around about 4 to 6 weeks, people can start to drive again. 6 to 8 weeks, if you've got a light job, not a heavy manual job, you might consider going back to work part-time. But by 3 months, most people, as I said before, don't really think about their hip very much, and they can do pretty much what they like. So that's the sort of that first phase of recovery. The first 6 weeks is the hard bit. So week 6 to 12, gradually getting more used to things and less pain. And then that first year, it does take a year, I think, to 18 months to really to reach the end point of the surgical journey. And again, that comes back to our psychology and physiology. If we have an acute event in our lives, it takes 12 to 18 months to adapt to that. If you have an acute illness, bereavement, they're very much the same types of psychological insult. And it takes us a while to accommodate and shift our focus and balance again. Same with surgery.
Yeah, indeed. And sort of, I guess on a related note, now there's, but by and large, as you well know, most people who have a hip replacement are in a significantly better place, a few months down the line after surgery than they were before. However, we've had a few questions in from people who still find that at 6 months or even 1 year after surgery, the pain is certainly improved from what they're saying. And there's three people who've sent in and say that like pain is better, but I still don't quite trust my hip fully. Or some days it feels quite heavy. Some days I have a limp. What would you advise those who are not quite sort of fully in the ideal progress at 3 months, 6 months, or even 1 year?
Yeah, well, again, it comes back to this sort of distribution of normal behavior. Yeah. The majority of people will be fine within 3 to 6 months of surgery. Some people are still under the curve, just under that bell-shaped recovery curve, and maybe at the one end of it, so just taking a little bit longer to recover. I think if you have concerns about your rate of recovery, and the trouble is, people who have joint replacement surgery are often surrounded by other people who are in the same boat. They're living in a world where their friends and family have had similar things, and they're saying, well, by 6 weeks I was doing this, that, and the other, and they're thinking, oh God, I'm not ready for that yet. So there's a lot of sort of, positioning, I think, that people say, yes, I was far better than that. I had my hip done here or there or by him, and I'm far better. I'm absolutely fine now. But that's just human variability.
Yeah.
I think if you have serious concerns, the best thing to do is get in touch with your surgeon and ask, what's going on? I'm not better. I get emails and phone calls from patients saying, I've still got a niggle of pain when I do this, that, the other. I listen to them. If necessary, I'll see them and we can examine the hip, look at it in the context of their other problems, arrange further investigations if necessary. The vast majority of these problems are just part of what led up to them having the hip replacement in the first place. They've got some back disease, degenerative disease of the lumbar spine, dodgy knee on one side, other things going on which will slow down recovery. In a very tiny proportion of people, there is a problem, perhaps a mechanical problem with the hip joint. Something's wrong, it's a little bit loose, or there's deep infection. Now, there, of course, that's my job as a surgeon, is to identify those patients with a significant problem and then go through a diagnostic pathway. But the vast majority of people who've got those niggles will find by a year they've all gone away.
Yeah, absolutely. I think so. So hopefully that will be quite reassuring to the people asked.
Yeah, I mean, most problems are self-limiting, generally. Some aren't, but that's where we have to step in and see patients and assess them properly.
Yeah, indeed. And so on a related note there, to ask a fairly specific question about one of the possible complications that can occur. It's from someone who has had a bit of a problem with one of their nerves. So there's this thing called a femoral nerve palsy.
Yeah.
And they just want to know your thoughts around femoral nerve palsy. How common is it, and what are the options in terms of improving it, treating it, so on?
Okay, well, there are three main nerves around the hip joint. There's the femoral nerve at the front, so in the groin. There's the sciatic nerve at the back, coming out of the back and into the buttock and then down the leg, and the obturator nerve, which goes down the inside of the thigh. The femoral nerve is unusual to injure that in hip surgery. Most surgeons in the UK will do what's called a posterior approach to the hip. Mm-hmm. So they're going through the back of the hip joint. So the femoral nerve is quite a long way away from that approach. Mm-hmm. So it's very unusual to damage the femoral nerve in that situation. If an approach is being used where the femoral nerve is vulnerable, some people do the direct anterior approach and it can be vulnerable in that. The nerve can be crushed or stretched or bruised. The vast majority of these nerve injuries will recover unless the nerve has been completely crushed or cut, in which case there's no recovery. Most of them will recover, but it can take several months to feel that one is getting back to some sort of normality. And there may well be persistent symptoms forever, because a damaged nerve can form what's called a neuroma. So the endings sort of get a bit jaggly and chaotic, and they can cause persistent symptoms. The femoral nerve supplies the skin and muscles in the front of the thigh joint. And so if you have a femoral nerve injury, it can cause quite profound weakness of the quadriceps muscles at the front, which will, of course, have a significant effect on mobility. So the crucial thing is to identify the extent of that injury. So the surgeon will have a good idea whether or not the surgery that was done put the femoral nerve at risk. And if there was an injury, that should be identified, and the surgeon will then take appropriate steps post-operatively to counsel the patient and arrange for some investigations. What we normally do is arrange for the patient to have EMG studies, electromyographic studies, to test the nerve, to see if it's injured, if it's transmitting impulses along its length, and if it isn't, where is the level of the injury? Yeah. And the electrophysiology doctors can say pretty precisely the level of the injury, how extensive it is, and of course then what the prognosis is. Femoral nerve injury is pretty uncommon. There is a type of, it's not the femoral nerve itself, but it's a branch of it. It's a branch of the nerves around the top of the thigh called the lateral cutaneous nerve of the thigh. And that emerges just below the pelvic bone at the front. And that supplies an area of skin over the side of the thigh. Now, some people, the nerve is a bit more exposed than others. It's nowhere near the operative site, When we position a patient on the operating table, the pelvis is supported by padded supports, and the nerve can be squashed there a little bit, and that can cause a burning sensation along the outside of the thigh, which can persist for several months, but that usually gets better. That's a condition called myalgia paresthetica. And it can happen on its own. It can happen spontaneously as well. It's a bit like carpal tunnel syndrome, that sort of thing, pain in the hand. These are nerve entrapment problems, and they're much more common. Not common after hip surgery, but just common in our bodies. Carpal tunnel syndrome, ulnar nerve entrapment, that sort of thing.
Well, thank you very much for that answer. And it's quite a specific question, and as you say, not necessarily
very uncommon.
Very uncommon experience, but hopefully that answer has been helpful to the person who sent that in.
Hope so.
It's about touching on the very common, and then also I think worthwhile,
of course, yeah,
on a few of these questions as well as they come in. Another one that we've had just now from Facebook is sort of moving outwards, so to speak, and it's about wound healing and particularly scarring after a hip replacement. And so this is from someone who is now 14 weeks on after their hip replacement operation, and they're a bit concerned about the scar and what are the best things to do, and would you recommend? I think they've been doing some reading online, and there's various creams and silicone strips and silicone ointments and that kind of thing. What's been your experience with that? Do they make a difference?
The hip's quite a forgiving area for an incision. It usually heals that without any problems at all, to be honest, in my experience. One respects what I call the tissue planes and the way the skin folds are. You can see on your own skin where the folds are. If you make an incision in the line of a fold along its long line, it will heal up without any problems. If you cross over those long lines, that's when you get problems. Now the hip, the lines in the skin are very forgiving in terms of where we place our incision for surgery. Some people are more prone to getting scar tissue than others. There are some ethnic differences. Particularly people from Africa can form what's called keloid, which is a thickening of scar tissue, and it can be quite unsightly. And the trouble is, if you try and remove it surgically, you're just sort of repeating the process. The majority of people undergoing hip surgery in my practice will have a red line, which persists for about 6 to 8 months or so. In the first few weeks, there can be irritation of the skin because underneath the incision, we put absorbable sutures to hold the edges together, so there's no tension there. Those absorbable sutures will dissolve and fragment at about 8 weeks after surgery, and that can cause local irritation, which can persist for about 6 weeks or so. And maybe that patient's got that. It's just that a localized inflammatory reaction to the absorbable sutures. Mm-hmm. I recommend they get some bio oil or some E45 and just massage the area gently a couple of times a day, help to break down the adhesions, stimulate the blood flow, and that usually resolves the problem in 99% of people. Obviously, one has concerns about wounds which are persistently uncomfortable, and that's when we worry about infection. So I think, again, it comes back to that. If you have concerns, speak to your surgeon. Yeah. The surgeon's the best person to know in the context of what's happened to you and all the other patients in his practice what the problem is.
Or her practice.
What's that?
Or her practice.
Yeah. Must be inclusive. Yes, I'm increasing numbers of women, particularly in our area, in the Wessex region. Lots of women trainees, which is great. Yeah. Orthopaedics is going to be very different flavour, I think, in the next 20 years or so. Which is good. It's evolved. It's not the sort of the old dinosaur speciality that people perceive it is. It's a very dynamic field, orthopaedics, and good to see hugely diverse numbers of people being attracted to it, because it's a great job. But doing hip replacements day in, day out, I never tire of it. Actually, it's just one of the best operations ever invented in my book.
No. I see. I've noticed. See, we're coming up to the hour now, and it's
okay.
I think we can carry on at great length because there's a lot more to cover. But what I think we should do is to double back and ensure that we perhaps cover the past few questions that have come in. We've had some on Instagram, we've had some on YouTube, and another on Facebook. And also, before we move on from scarring and the sort of wound care side of things, with my safety hat on, I think scar tissue massage, absolutely, there's a lot of good evidence for it. But
Yeah,
As ever, check in with your surgeon about it first.
of
The wound
course.
needs to heal to a certain degree before you start applying bio oils and that kind of thing. Although they can help, the wound needs to heal on its own for a period of time first. But absolutely, that can help with that.
Yes. Don't tinker too
No,
soon.
no, that's it. Don't tinker too soon. Now, so the questions that we've had in. So there's another one which I think is something that can be quite troubling for some people when it does happen, and it's about clicking of the hip
Oh, yes.
afterwards. And is that normal? Is it a sign of a problem? Is it likely to be indicative of something that could develop? Is it likely to go away on its own?
Okay, it's an interesting one. And obviously, clicking can be a concern because we're putting I'll show you. I'll just show you some hip replacements because you can see where we are with those. Let's switch over to this. So here's some hip replacements, and you can see that hip replacements, a mechanical beast comprised of different parts which go together, and they can sit in a socket like that. And you can see that terribly well there. So when we walk and get up out of a chair, the hip replacement can just separate slightly out of its bearing. It's not usually a problem, but that might be the sensation that somebody's perceiving, that as they move and the hip replacement moves, it just might subtly separate a little bit. And that can be perceived as a click. Things like hip resurfacing. Here's a hip resurfacing. That's made of metal. Use these in selected cases. But again, that sort of separates slightly under certain loading and movement conditions, and that can cause a click. The vast majority of clicks are due to muscular things. So over the bone of the hip joint, particularly over the upper outer bone that you can feel when you press onto your hip, there are muscles and a bursa which overlies that. And the bone can be a little bit roughened when you have arthritis. And what most people are probably feeling is the feeling of those muscles going over rough bone. It can cause a type of bursitis or tendonitis. And that's what the majority of people are feeling. Obviously, a persistent clicking, particularly if it's associated with pain, is a bit of a red flag. And again, it's one of those things you should talk to your surgeon about, the fact that you've got some clicking. An examination, maybe an up-to-date set of radiographs or an ultrasound scan will usually give the diagnosis. But it'd be a very small, tiny percentage of people who would have a mechanical problem with their hip joint, which would cause clicking. But it's good to know if it's a new symptom or it's associated with pain or you're worried about it, just speak to your surgeon.
Yeah, absolutely. I think that's yeah. So by and large, clicking on its own need not be too concerning, but with pain, then perhaps it is. And generally speaking, as with any concern, speak with your surgeon. Absolutely.
Yeah, it's a bit, it's a bit like a car. When it's new, you don't hear anything, but you run it in a bit and little bits of squeaks and rattles. But our bodies, when you turn your head, you can hear grinding in your neck. It's all part of this. And people, I think, and it's understandable. I'd be the same if I had to have surgery. Yeah. You're so terrified of the complications you've been told about. You think that anything that's out of the ordinary that you experience can be blown out of proportion very, very quickly. Yeah. And people can catastrophize these things. Oh God, the thing's going to dislocate, or it's going to fall apart, or it's not put it in properly. And of course, those are totally understandable concerns. Yeah. Because you've got something in you which you've never had before, and it's a totally novel experience. And you're quite rightly going to be absolutely in tune with things, thinking, is this the beginning of a problem? So speak to your surgeon. I think that's the best thing. Or phone the clinic, speak to one of the nurses. The nurses I've worked with over the years have huge experience of the sort of symptoms that patients discuss with me. And most NHS units particularly work in large teams, arthroplasty units, so joint replacement units, where there will be physios, junior doctors, fellows, nurses, the whole panoply of staff who will be able to answer concerns. And it comes back to what we said right at the beginning. There will have to be put in place, and already are being put in place, telephone consultations, particularly for these sorts of symptoms where you don't want to travel 2 hours to get to the place where you had your hip replacement done, just to be told by someone that you're absolutely fine. Far better just to phone up and describe your symptoms. The person who's taking the call will say, okay, that sounds absolutely fine. It's what most people experience at this stage. keep an eye on it. If it persists, call me back. Or I don't like the sound of that, you need to come back and see me. So that's going to be, and it already exists. I do that myself. But I think we'll see a much more formal structure in terms of that type of advice and follow-up.
Yeah, absolutely.
Yeah.
Well, I think we're getting more excellent questions, and I think there's easily enough to pad out a whole separate session.
We should do it again.
Yeah, no, we should indeed. But so to finish off, I think I will also say we're getting some wonderful feedback on this call, and people finding it helpful. So that's good to hear too. And please do send in more questions. I think we are running out of time today, but we'll absolutely look forward to digging deeper into more issues with a separate session. But to finish on a final question, which is one that's come up a few times and with some variations, is how long can I expect my hip replacement to last? And related to that, what can I do to make it last as long as possible?
How long is a piece of string, Axel? It depends on so many variables. You know, how old you are when you first had it done, what the diagnosis was, what you do for a living, what your lifestyle is like, how heavy you are, all sorts of things. If you look at the statistics, a very good paper from the Lancet last year looking at National Joint Registry data, showing that if you have a hip replacement in middle age, so over the age, say, of 55, there is 70 to 80% chance that your hip replacement will last you 20 years, as long as it's been put in reasonably well and you don't go off and jump off mountains with it. So that's the sort of expectation. 50% of hip replacements will last 25 years or more. Yeah. The younger you are, the more complex the problem. You know, if you're a 25-year-old with a severely malformed hip, your hip replacement's probably not going to last as long as someone who's in their late 50s, early 60s. And that will be part of that decision-making process that you will go through with your surgeon. Setting those expectations out in terms of the short and medium term, you know, getting back to work, raising your family, all those sorts of things, and then thinking perhaps maybe in your 40s you might have to have another hip replacement operation. Yeah. So life is uncertain at the best of times, but rest assured, the vast majority of people who are in that middle-aged and older demographic will have a hip replacement which will almost certainly last the rest of their years and allow them an excellent quality of life.
Well, I think that's a wonderful and positive note to sum up for a really enjoyable call. So thank you so much, Mr. Latham. It's been a pleasure, Axel. It's been a real pleasure.
And good luck with the app. Keep me posted. I'll keep an eye on it on Twitter, and everybody follow the app, and hopefully we will get going again soon. We're all gearing up for it in the background. Yeah. There's intense preparation going on. We're receiving updates from the Department of Health every day, from our local commissioners of healthcare. So everything's going on in the background. There isn't certainly no paralysis out there. There's a lot of noise, a lot of false news, a lot of hysteria. But just keep looking at the website. Follow Axel, follow me, and you'll get the truth out of us, I'm sure.
Yes, indeed. And we will make sure to put a link to Latham Hip Surgery, to your YouTube channel, in the description below.
Thank you, Axel, and likewise.
Yeah, indeed.
And we'll speak soon.
Indeed. All the best, everyone. Please
to everybody. Yeah. Have a good evening. It's lovely out there.
Yeah, it is. It really is. It really is.
Bye-bye.
I'm really sorry to those who sent in questions that we didn't get to today, but we will absolutely pick them up and cover them at an upcoming session. So please do send in more questions, and also feedback on what you thought of this interview. Was there something that we should have covered a bit more? Was there something that you felt we could come back to on another session? Then please do let us know, because we will. We absolutely will. And so until next time, be well, stay safe out there, and keep up the good work. Thank you.
Thanks, everybody. Bye, Axel.